All right, good morning. This is the internet live session for the lower extremity osteotomy and deformity course. I'm the moderator of this session, and we're doing the Diaphyseal and Distal Tibia module. Mitch Bernstein, Sean Nork, and Tim Weber are the faculty for this module. And these are our disclosures, none of which are particularly relative, except for maybe in Mitch's talk regarding some of the bone void or bone loss techniques. We are recording this session, so if you do not wish to be included, leave your camera off and turn your microphone off for the entire session. We'll do that anyway. Your microphone will be muted, and that all the rights for this presentation are owned by AO North America and the AO Foundation. As far as Zoom meeting etiquette, everybody's done Zoom meetings or something like it. Please, when you have questions, we'll have question and answer sessions. Please make sure that you use the Q&A function. This allows us to keep track of your questions and helps us shape the next event that we have. And it also, because it allows us to record it. We do have a final date for the live event, and so this will be November 13th through the 14th at the Aquindo Center in Las Vegas. And so it'll be a Friday afternoon and Saturday morning. We're trying to be cognizant of everybody's time, so you could potentially fly in that morning, have an afternoon session, and then do a morning session on Saturday. And then we're going to have a full day of practicals. We're going to have cadaveric osteotomies, synthetic bone planning and osteotomies. And the goal is to have a 2-to-1 participant to faculty ratio based on availability and people interested. That may be 3-to-1 potentially. We also are looking at potentially doing other live events in different regions later on, but for this year it will be only in Las Vegas. And then we're also going to have a Saturday night event with the faculty to encourage mentoring as well as just forming relationships to take care of these complicated patients. So we're really hoping that the live event happens based on all of the pandemic issues that are going on. So the learning objectives for this session include list the indications for tibial deformity correction and non-union management, utilize deformity correction techniques to restore extra-articular alignment, utilize operative techniques for distal tibial intra-articular osteotomies, and recognize strategies for leg lengthening and bone transport. So these are our faculty for today, as you can see outlined in the picture frames. And they're awesome. So we're going to have a great session. This is the agenda. It's 35 minutes for the diaphysis, and we'll have Mitch Bernstein and Sean Nork discuss these techniques. And then we'll have a break for questions and answers and summarizing that specific session. And then we'll move on to the distal tibia, where we'll have extra-articular deformity being presented by Tim Weber. And then the entire panel is going to be involved with a couple of intra-articular osteotomy cases. We'll have a short time for questions and answers outside of what you can ask during the panel discussion. And then based on time, we'll have some more cases to go through and summarize the module. So Mitch will start us off with non-union, dealing with bone loss, including bone transport. And then Sean will move on to malunions of the diaphysis for indications for osteotomy, and particularly going through the mathematically directed single plane osteotomy. So with that, I will turn the screen over to Mitch.
All right. I don't know if I should say it, but can everyone hear me? Can anyone hear me?
Yes.
Yes.
Okay, thank you, thank you.
Yes.
Okay, this is going to be a wonderful lecture. We're going to talk about bone loss and bone transport in the tibia. At the end of this lecture, I hope you guys would be able to appreciate the reconstruction ladder for bone defects and a little bit about the algorithm that I use, as well as the formula for the Elizarov method or distraction osteogenesis, and execute a plan for bone transport. So reconstruction ladder and the algorithm. I think you need an algorithm and some sort of reconstruction ladder when dealing with non-union particularly if there's bone loss. So in 10 minutes, a little challenging, but we will get through it, and with some principles. So basically, it's all about the personality of the non-union. This has been discussed throughout AO, and I'm sure a lot of us trauma surgeons appreciate this. So it's really about the lesion and what type of non-union we're dealing with. So for example, this is a ex-Marine who has a 65 millimeter distal tibia defect that's infected with a flap that is draining pus. This is a patient who's not well supported or educated socially. She has a mobile non-union at the proximal tibia. This has been revised multiple times. This is a patient that I treated acutely, and that's 7 days out from an open tibia fracture with a bone defect that's been set up by the same surgeon that's doing the transport. And this is another patient who was on a motorcycle to type 3A with about 15 centimeter defect that is about 5 days old, being treated by a surgeon in a local community. So as you appreciate, some of these non-unions are different, and they have different issues to deal with, and you got to deal with them with different priorities. So for me, I like to consider, is it an acute or a chronic lesion? Is it a 3A or 3B? That is there a soft tissue issue? Do you need to put a flap on? Is there a flap already that needs to be elevated and closed? Is there a flap that's failed? Is it infected, or do I need to rule out infection? I would never really go into these thinking it's not infected. And this concept of total bone loss, where you have a bone defect and you need to appreciate and work up, is there an existing limb length discrepancy in addition to the defect size? And that'll give you an idea of the total bone loss. What kind of host is it? What kind of host factors are you dealing with? Is it a smoker, diabetic? How old is the patient? What kind of support do they have? And a lot of us work in referral centers. How far away did the patient come? Are they going to be able to come back every week or two for treatment if you're doing some sort of bone transport? And again, is the lesion Diaphyseal or periarticular? So this is just an example of a patient who's been treated at our institution since 2006. Today, we're in 2020, so it's 14 years ago. He has a very complicated non-union of his tibia, but just for the point, he's wearing an 8 centimeter block under his right leg. So if you want to get this non-union to heal, you have to consider also he's missing 8 centimeters of a bone. So our principles of treating patients with broken bones, there's the AO principles and the Elizarov principles. And I really wanted to put this slide in because I like to compare Elizarov teaching with what we're taught in AO. So they're basically identical. So anatomic reduction, stable fixation, preservation of the biology, and early range of motion is all what Elizarov proposed in his teachings. And again, this point number 2 of preserving this osteogenic tissue as it pertains to non-union treatment and what type of tissue you're going to excise versus keep. And if you just add some non-union principles when treating patients, you want to remove non-osteogenic tissue or non-viable tissue. So for example, in a hypertrophic non-union, the tissue in there would be considered osteogenic. So you can argue you don't need a formal debridement of that non-union site. And stability, are you going to achieve stability with new surface implants? And if so, is that an issue with infection? Or do you need stability with a circular fixator or another type of external device? And of course, treat infection when present. So indications for bone transport, I like to think of it, are you doing post-traumatic limb reconstruction? And there's the issues to consider: massive bone loss, poor soft tissues, infection, and you're going to need prolonged stability. Is it an acute reconstruction where these are acute traumas and you know the patient's going to need a bone transport? There's a lot of devitalized segments of bone and soft tissue, and you know this patient's going to turn out into some sort of bone reconstruction with transport. So here's an example of a 46-year-old patient who had an open tibia fracture, type 3B, was treated with an IM nail and a cement spacer and the ORIF of the fibula. Eventually was referred on 8 months later and has been non-weight bearing. And there you can see the leg does not look infected, has had a flap with skin graft and a wound that healed over, but wasn't really draining any pus, has an equinus contracture. Now you got to come up with a plan to fix it. So my plan was a formal debridement, and if there's a flap, I like the debridement because the plastic surgeon gives me access to the entire bone where you can remove all non-viable tissue. And your debridement, if you're doing a transport, you want flat cuts on your tibia versus some sort of inducible membrane. You may want to keep those large spikes for surface area. So again, this concept of removing all non-viable tissue from skin down to bone is critical. Dr. Serkin talked about last time about cultures and how to obtain cultures, how many to obtain. And you really want to make sure you have bleeding tissues. You want good soft tissue coverage, and you want stability. You need good stability and prolonged stability. So this patient underwent a bifocal transport. There's a corticotomy at the top. This is a double level stacked hexapod and had compression or shortening at the defect site. And of course, this is the Elizarov method using a stacked hexapod, but these follow Elizarov principles. So this is where the bone forms osteogenesis. This defect closes, and this site will eventually fuse, and that's an example of a bone transport. This patient had 75 millimeters of total lengthening, and again, in lieu of our course, again, auditing your alignment and making sure your sagittal, coronal, angular, and axial parameters are good. And you want to make sure once you do this transport and keep her leg, she actually has a good looking leg to walk on. And that's her standing hip to ankle at the end, showing her mechanical axis and as well as her limb length. Of course, they get scarring. These are external fixators. So over time and currently we're moving towards what's called integrated techniques, which are techniques that combine external and internal fixation. And then of course, most recently, all internal techniques. So these are just examples of integrated techniques and all internal techniques of dealing with massive bone loss. So this is just an example again of a double stacked bifocal transport using a hexapod. And on the bottom, you can see the, can you guys still hear me? I may have lost my AirPod Pros.
You're good.
I'm putting double ears in. So this is a EFI of 2.5 months per centimeter. That means for every centimeter of lengthening, this patient's in the X-fix for 2.5 months. So this is a real pain in the butt for the patient. This is very cumbersome and quite irritating. So this is a type of integrated technique. This is lengthening and then nailing. So we're doing a bone transport into an ankle fusion. So you're doing your distraction osteogenesis with a hexapod, but then you're stabilizing the regenerate with an IM nail. And you bring down your EFI to 1.5 months per centimeter. This is an example of a cable pulley transport. This is the clinical, well, this is the x-ray of the patient I showed you a couple slides ago. This is a type 3A open tibia fracture, eventually had excision of a devitalized segment and was left with a 15 centimeter bone defect. So I learned this from my mentors in New York. This is a cable pulley transport over an IM nail, type of integrated technique. So we clean up the fracture ends, make sure the bones are cut flat, and set the patient up for a bone transport. This is just an animation of it. These are Elizarov cables. So steel cables are passed over the anterior cortex and through the anterior cortex of the tibia. And those are eventually passed through the soft tissues. So this is an example of that patient. And then you put on a simple motor or an external fixator with clickers and pulleys. And as you turn the clickers, the transport segment is pulled down over the intramedullary nail. The advantage here is once you are pulled all the way down, you can stabilize the docking site and stabilize the transport segment, and then you can remove the external fixator. So this is the x-rays of that patient as the transport segment is being pulled down. You can see there's a custom hole in the IM nail. The regenerate occurs at the top, and you can see this is right after the X-fix is pulled off, and here's 6 months later, you can see there's excellent regenerate that forms around the IM nail. And what's amazing is the EFI, the 0.41 months per centimeter. So significantly less than if this patient needed a 15 centimeter defect with an X-fix alone. This is final clinical photos and standing hip ankle X-rays. So this is from Steve Quinnen. So he uses a cable transport, balanced cable transport with X-fix. So an example here, this is a balanced cable transport alone. Those patients have an EFI of 1.84 months per centimeter, and then not shown here, but what he does also is as soon as this is done, he drops in an IM nail and then decreases the EFI to 0.36 months per centimeter. So these integrated techniques are amazing at decreasing the time of the patient being in the external fixator. All internal techniques which are new. Admittedly, I have not done a plate-assisted bone transport yet, but these are rare cases. There's usually not large trials of these, mostly case series and case reports. This is an example of an all-internal technique with a plate-assisted bone transport. This is a patient of mine that I've not treated yet, but he's going to be set up for a all-internal solution with a bone transport intramedullary nail. So in summary, I think, I've talked about the Elizarov method a lot. I haven't talked about inducible membrane, the Masquelet technique, that's just for sake of time. But the Elizarov method is a very powerful tool for limb reconstruction, and all the different devices, implants we have, all use the Elizarov method and science behind it. So you have to adhere to those principles despite the new fancy toys that we have to use. I think there's really no right way, and we've seen that throughout this course. We should learn to combine strategies, and there's a lot of different ways to do things. I think we're going to see a lot more of these integrated and all internal techniques. Thank you very much.
All right, next, Sean will start going over the Diaphyseal osteotomy section.
Okay, good morning, everyone. I'm assuming you can hear me. Yeah, and thanks very much to Brett and Mike for all the work they've done with this course. Originally, we had this oblique osteotomy section and mathematically directed osteotomies in the femur section, but we decided to move clamshell to femur and mathematically directed osteotomies to the tibia because it's just much more common in this location. So I'm going to talk specifically about the mathematically directed single cut osteotomy. Right from the beginning, this talk is made really to inspire people to think about this osteotomy, not to intimidate. There is some math involved. But I think if you take a systematic approach, you really realize that a lot of deformities can be corrected with a single cut. It doesn't mean that's necessarily what you're going to ultimately do, but if you go through the math, you will really understand the deformity. And whether you end up doing a transverse osteotomy and an intramedullary nail, you will still understand it better if you've done the math. So in order to get there, I think we need to walk through some basic principles. Now, all of this is based upon some articles that came out in 1989. And so Bruce J. Sanjorzen is my partner. He's a foot and ankle surgeon. We've been partners for 23 years. His brother is Bruce P. Sanjorzen, who's a physicist in Michigan. And they had published manuscripts on this. The manuscript from the Journal of Biomechanics goes through the derivation of the formula associated with this. that one may be a little rough. But if you go to the one in the Journal of Orthopedic Trauma with clinical applications, it has all the necessary graphs that you would need. You just have to read the article very slowly, but I would encourage everyone to get these. So what types of malunions or deformities can be treated with a mathematically directed single cut osteotomy? Well, you can see it here, and this is on kind of Matt Graves' deformity analysis matrix. If you look at a deformity where there's angulation and perhaps with an axial plane issue in terms of being too long or too short, you can use a mathematically directed osteotomy. It's just not applicable if there is associated translation. So it can't correct that. You will definitely end up with a Z deformity and a mechanical axis deviation. But it can simultaneously correct angular and rotational deformities, and you can add length to these. So this is a case of a 22-year-old, and we're going to come back to this case. We printed some 3D models of this particular patient this week. This is an osteotomy, though, that I did years ago, but just so that we could have a few demonstrations, and that's what I was doing all day yesterday and last night, is playing with 3D printed models to try and make this a little more clear. So rule one, and this is consistent with what Rafi Neiman had presented about 5 weeks ago, that an angular deformity in multiple planes, so if you look at a deformity on an AP and a lateral radiograph, and if there's angulation without translation, you can calculate that as a single angular deformity. And Rafi went through that. And therefore, with that same calculation in two perpendicular planes, you can identify a no deformity and a maximum deformity view. And I would encourage you to go back and look at Rafi's presentation, but we'll run through that again because some of the calculations that we do with that simple first step of understanding the deformity will apply directly to a mathematically directed osteotomy. So for instance, in this patient, and she's in her 40s, she came from Southeast Asia, was treated over 20 years prior to referral, and you can see the deformity that she has. And so I'll go through this quite quickly because these are the same calculations that Rafi had done, and I'll try and show you the relevance to a mathematically directed osteotomy. So first, if we look at her, she has obviously a coronal plane deformity, and we'll call that 25 degrees of valgus. Then she has an associated sagittal plane deformity, and we'll call that 10 degrees of extension or apex posterior. And so if we just do the square root of the sum of the squares, so the square root of 25 squared, which is 625, plus 10 squared, 100. So the square root of 725 off the top of my head is 27 degrees. So that means this patient has a single deformity. At its maximum deformity, it's 27 degrees. Where is that deformity located? So since we have a simple triangle there with a right angle, we can just do a little trigonometry. We all learned this, but chose to forget it in large part. And I changed it to alpha, and we're going to call this alpha only because in the mathematically directed osteotomy, theta is very different. So calculating that angle is just the arctangent of the opposite over the adjacent, so 10 over 25. And this is on everyone's iPhone. If you just go to your calculator, and if you turn your iPhone sideways, you'll be able to do tangents and arctangents. And we quickly find that angle alpha is 22 degrees. So if you rotate the limb from the coronal plane 22 degrees, you will find the maximum deformity view for that leg. And 90 degrees to that will be a no deformity view. So this leg in the operating room looks like this. So on the left, I think you can see this, the no deformity view. where it is perfectly straight, and on the right, you can see the maximum deformity view at 27 degrees. So if we want to talk about a single plane cut, we start to consider, gosh, could I do a long oblique osteotomy, either descending or ascending, to correct that? And the answer is yes, but we'll have to do the math and we'll have to talk about some of the problems. Okay, so first I'm going to just start with a straight up oblique osteotomy, and then we'll talk about how to calculate the mathematically directed. So here's a 42-year-old. He got sent to me about 2 years after someone had fixed his tibia. It was partially healed, but it was quite hypertrophic. About 6 months later, and after multiple procedures to resolve his infection, you can see he's well healed with a large amount of both posterior and lateral callus. You can also see some antibiotic beads in place. These are his standing films, and I think all can appreciate the valgus deformity. So it's a single plane deformity where the cora is. But you can also see the problem as you think about ways to fix this valgus malunion of the tibia. I certainly was not very interested in doing a transverse, a closing, or an opening wedge osteotomy through that mass of healed callus that's about the size of a grapefruit. So I chose to do a long oblique osteotomy that avoided that large amount of bone posterolaterally. And I think you can see that plane of the osteotomy. And that allows me to correct the coronal plane deformity that you can see. And it's an incredibly stable osteotomy that just hinges and rotates about the center of that obliquity. And this goes on to heal very predictably, and that's after plate removal. So a simple oblique osteotomy is just parallel to a no deformity view and perpendicular to the maximum deformity view, and that sure seems simple. However, you get rotation with an oblique osteotomy, and an oblique osteotomy will introduce a small angular deformity on the no deformity view. So here is a 3D printed model of that young gentleman that we're going to talk about in more detail. And I tortured our IT guy this week and made him print up 5 of these. The large 3D printer wasn't working, so you can see he had to segment these and glue them together. With one of my fellows, we spent the whole day yesterday just trying to work with these models. It didn't really work, but hopefully we'll get some useful information out of these. So this is one of those models. After I've made a cut, and you can see I've put in just a few transverse wires, one at the proximal tibia, which is away from us, and one at the ankle, just to show as we go to correct this deformity from varus to straight, what happens with the rotation along a long obliquity. It's about a 60-degree obliquity, but you can see in this, just by straightening this, the external rotation that is introduced, and then we'll go back to the deformity. You can see it internally rotate. Now on the no deformity view, with this model, which is about a 45-degree cut, you can see that you would predict that you wouldn't get much deformity on the no deformity view, and I'm emphasizing that by overcorrecting this, but you can see you introduce a small deformity on the no deformity view with an oblique osteotomy. Hence the mathematically directed osteotomy, which is nothing more than a single oblique cut, but we have to determine how steep to make it and where to make the plane of the osteotomy so we don't have those 2 issues. Those 2 issues being the introduction of torsion and the introduction of a deformity on the no deformity view. So the first question I hope you have is, does it matter whether you do an ascending or a descending oblique osteotomy? And so of course it does. If you do it in one direction, you're going to correct the rotation. simultaneously, as we demonstrated. But if you do it in the wrong direction, you double the rotation. Because you may approach a patient and say, they've only got a 10-degree rotational malalignment. I'm just going to ignore that, do an oblique osteotomy. It won't be a big deal. But instead of taking it from 10 degrees to 0, if you take it from 10 to 20, that may be a problem. And that can be solved by just getting the direction correct. And the way to do that is to calculate it. So I'm going to go through this patient quickly. Then we're going to look at the details and then go through a little more slowly so that people are comfortable with these calculations. So here's our young patient. We'll measure the coronal plane deformity. So he has a 22-degree varus deformity. He has no sagittal plane deformity. And based upon the CT scan, he has a 15-degree internal rotation deformity. So he still has external tibial torsion, but compared to the other side, he has 15 degrees less external rotation. So he has a 15-degree internal rotation deformity. So his true angulation, or his maximum angulation, is just his coronal plane deformity, which is 22 degrees. The plane of the deformity is 0 because it's all in the coronal plane. And what the mathematically directed osteotomy will help us calculate is how steep to make our osteotomy, angle theta, and where should that plane be relative to the no deformity view. That's angle phi. So these are our deformities. He's also about 13 millimeters short. Remember, on one of those early graphs I showed, you can correct angulation in all planes, rotation, and you can take care of a little bit of axial malalignment with lengthening at the same time. So if you go to the Sanjorzen articles, you can plot this out. So once again, he has a true angular deformity of 22 degrees, a torsional deformity of 15 degrees. And if you look at this plot, you calculate an angle theta of 56 degrees, and that's graphically depicted on the left. So that tells you how steep that osteotomy needs to be. So quite steep because there is not a large rotational component. Now we have to calculate angle phi, and that's how much do we externally rotate the plane of the cut relative to the coronal plane in order to make sure that we don't introduce a deformity on the no deformity view, and to make sure that we get the ascending descending issue in order. So you first plot out to calculate angle alpha, but just remember, we already did that. And we knew angle alpha was 0 based upon our initial measurements. Then we take that, plot this on a second graph, and we find that angle phi is 7.5 degrees. Angle phi is going to be 1/2 of the torsion relative to the no deformity view. If angle phi is positive, that means the plane is externally rotated. So we have all of these values. We really understand the deformity. We understand the plane of the deformity. We know we need to make a steep osteotomy that's ascending from distal to proximal at 56 degrees relative to the transverse plane. And it's going to be 7.5 degrees laterally rotated. So all of that to produce that single cut. Then we fix it with lag screws in a plate. And like I said, we'll come back to this and just go through it a little more slowly. Now, I know what you're thinking. Everyone's like, okay, we don't have perfectly perpendicular radiographs, so none of this is accurate. But I would argue we can obtain good quality radiographs at 90 degrees so that we can calculate exactly the deformity and the no deformity view. So you can't measure 7.5, 27, 56. But I'll argue that you can, and there are ways to do this, and I'll show a couple of images of how we can get accuracy, both for the plane of our osteotomy and also a slight rotation of the limb in order to make sure that we correct for angle phi. And we've all heard this in orthopedics. And yes, it is true that we are taking a big, huge saw blade. But I think the important thing is to do the math and get this thing incredibly close. And I think you can be quite precise. Now, it's interesting, about 6 weeks ago, I was giving a presentation to some of our fellows on taking care of malunions, and two of our fellows are engineers, and it's Joe Patterson and Steve Wallace, and these guys are amazing. They both independently took Sanjorzen's articles because they were a little bit frustrated, I think, with the imprecision of putting a dot on a graph and then trying to determine an exact number. Joe's going to be at USC next year, and Steve Wallace is going to be in New York at HSS doing a deformity fellowship. And they took all the original articles, the original graphs, and the understanding of deformity analysis, just a little bit of math for you sprinkled on top from the article, but then they put it all in an Excel file in order to calculate angle theta and angle phi exactly. And everyone's going to ask me, and don't bother emailing me and asking for this. This is not ready for prime time. It hasn't been validated, and we don't want anyone to have something that's going to give you an inaccurate number. But we've run it on about 8 or 10 different deformities, and it sure seems to work. And I'll show you an example of it. But you can see it gives you not only angle theta and angle phi to take away some of that mystery, but it will also tell you how much the limb length changes just by changing the geometry and spinning on the oblique osteotomy. So if we take this case, I'm just gonna like really quickly run through doing a calculation on her. So this is with their little calculator. So she has a 25-degree valgus deformity. She's got a 10-degree extension deformity, and she's got a 20-degree external rotation deformity. So what used to take me about 5 hours of staring at Sanjorzen articles and reconsidering quickly tells us that she's going to gain a centimeter in length just by correcting those deformities. Well, let me put in, like, I think if we put in some lengths on her, so she's got, if we measure her length, she's got about a 360 millimeter tibia, and those are her deformities. So I'm sorry, that gives her about a 17 millimeter increase in length. That gives us our angle theta, which is 54 degrees, which is relatively steep, and an angle phi of 148 degrees. And I'll get into what that means when angle phi is greater than 90 degrees. So this was this one that we had done before, and their calculator generates the exact same numbers, a maximum deformity of 27 degrees with an angle alpha of 22. So we come in with the coronal plane, sagittal plane, and torsional deformity. We can calculate the maximum deformity. We can determine the plane of no deformity. Then we'll calculate angle theta, how steep to make the cut. And this is always calculated as an ascending cut on the lateral view. And then angle phi will tell us how much to rotate that plane. So to reemphasize, angle theta allows a correction of the angular deformity and the torsion at the same time. A few rules about angle theta. It's calculated as an ascending cut on the no deformity view. As angle theta increases, the rotation that's introduced decreases. And that makes sense because as angle theta goes to 90 degrees, in other words, It's parallel with the long axis of the tibia, a tibial hemisection. That is the only way that you can do a coronal plane correction with no rotation. But obviously that's completely impractical. Whereas if angle theta goes to 0, that just means it's a transverse cut, and therefore there's infinite rotational correction. Angle phi. Angle phi is your friend. You need to calculate that, but she's a difficult friend to understand. And I think this is the toughest one, but hopefully I'm making it a little clearer so that you understand that this is just a correction for the plane of the deformity. It ensures that it's in the right direction and prevents you from creating a deformity on the no deformity view. So a few rules on angle phi. It starts from the coronal plane. It's defined with lateral rotation of the plane of the osteotomy as positive. It's always a number less than 180 degrees. If it's greater than 90 degrees, if that plane rotates around the tibia more than 90 degrees, that's where it transitions from being an ascending cut to a descending cut. I know this hurts. I know this hurts your brain a lot, but I think if you understand this, you'll really understand the deformity. As it turns out, angle phi is always equal to 1/2 of the torsional correction from the no deformity view. So that's a good check before you do this osteotomy to make sure you have it correct. Angle phi will tell you which direction to go. And it prevents creation of a deformity on the no deformity view. So this was yesterday. This is Steve Wallace, said one of our fellows. That's his coffee thermos with a paper plate, just so we understand these angles. So we just take that, and if we just push that down and now rotate that to the side view, that's just going to show our angle theta with an angle phi of 0. So we have not rotated the plane of the cut at all. So now if we look at this from the side, once again, there's our angle theta. And now if we rotate angle phi around the tibia to 180 degrees, you can see how that goes from being an ascending cut to a descending cut. So to summarize these confusing angles, angle theta is the obliquity necessary to correct the torsion. Angle phi ensures the correct orientation. So looking at him in just a little more detail, that's the CT scan. So once again, he has external tibial torsion, but it's 15 degrees less on the left affected side. Therefore, he has 15 degrees of internal rotation of the left tibia. He's 13 millimeters short. So if we go to the graphic representation and calculate this, we find that angle theta is 56 degrees, which is consistent with the plots on the graph. Angle phi is 7.5 degrees from the coronal plane, which is half the torsion. Angle beta just tells you how much you end up rotating the tibia to correct the tibia, but one doesn't use that. I mean, intraoperatively, you just make the tibia straight. And that also tells us that we're going to get 7 millimeters of length just by changing his geometry. So we have all of those values. So you don't need many tools for this. You might need some triangles, perhaps a goniometer. You need a saw that minimizes the kerf. This is it once again, on a sawbone. I put in a few reference wires just so we could confirm and understand the torsional correction. That's the lateral view, the no deformity view on this pure coronal plane osteotomy. I've just put in a wire at 90 degrees using a simple sterile goniometer to put in a wire at 56 degrees. So that's our angle theta. Then what I do intraoperatively is I'll put in wires along the plane of the cut if I have to do a long obliquity, and then cut along those wires. This is a case that I did a few months ago. And you can see we were doing a proximal tibial oblique osteotomy. So put in multiple wires and then just cut along the plane of those wires, because you really want that obliquity to be very pure so that you can rotate on it very nicely, that you can see there, a nice long obliquity to minimize the rotational component. So we're back to this 3D printed model, and this was our problem yesterday. The saw would just melt the model. We'll try it again for next year. That's uncorrected with a clamp in place, and then that's with correction. And I think if you look at the two images on the right, you can see the introduction of external rotation, which is what we want to do with that ascending cut as we go from varus to neutral correction. That's what it looks like on the AP. And once again, that was the cut. We gained a little bit of length. We were trying to get about 6 millimeters of length to make up for his 13 millimeter limb length inequality, 7 millimeters of which were going to be corrected just by the geometry of correcting the varus deformity. Intraoperative radiographs. So again, multiple lag screws, neutralization plate. You can see these osteotomies are healed by the recovery room because there's such a nice long obliquity. And that's him at 6 weeks and at 1 year. So take home. I think it's infrequent that you do one of these osteotomies, but it's very useful, and I think it's quite elegant. You have to do the math. You have to make sure that you correct the torsion in the correct direction so that you don't double it, right? Rotation is going to occur with every oblique osteotomy. How steep you make that obliquity of the osteotomy will determine the amount of rotational correction. Steeper osteotomies, less rotation. Relatively transverse osteotomies, much more rotation. The direction of the obliquity determines the direction of the rotational correction, and angle phi is critical for avoiding introduction of a deformity on the no deformity view. I hope that was crystal clear. Thanks very much.
Thanks, Sean. If you could stop sharing, yep, thanks. All right, well, that's a very difficult topic, and I think you did an awesome job of going through every step. We'll have just maybe about 5 minutes for questions. One question that a participant has is the ascending cut with reference to the anterior cortex?
Oh, I'm sorry, come again?
Is the ascending cut reference to the anterior cortex?
Yes. So a positive value is angle theta is always going to be relative to the anterior cortex in an ascending fashion from distal to proximal. That will be defined as positive. It doesn't mean you can't have a descending cut, but that's when angle phi rotates you more than 90 degrees.
Yeah, definitely complex. We are at the live event going to do this exercise on a sawbone, so that'll give people the opportunity to go back and watch this presentation. Particularly, this is a super complex osteotomy because of the math, but have the opportunity to review the YouTube video that will be posted, and then we'll do it at the live event. Mitch, if you can jump on, unmute your mic and get your video on. What do you think the advantage of a cable-assisted transport is versus all internal lengthening?
So in summary, like I wrote on my slide, there is no right way. So
they're making you choose, man. They want you to choose.
So It has to do with what you're comfortable with, number one, what you have in your hospital. The cable pulley systems need a X-fix stabilizing above and below. With the plate-assisted bone transport, you need a large surface implant with a lot of fixation, proximal and distal. If it's a small periarticular segment, I like a circular fixator to obtain stability as opposed to a plate and screws. And of course, you need to make sure your plate can get good fixation around your IM nail. Just some thoughts, obviously.
And then I think it's related to the mathematically directed osteotomy, but have you had any issues with non-union, Sean?
Oh, not with a mathematically directed osteotomy, just because you're usually not doing a massive rotational correction. So it's a long oblique in almost every case. I've never had one come up to be less than 40 degrees, and they're usually around 60 or 70 degrees. And just because of that, there's such a huge surface area that's flat, and it was produced in an atraumatic fashion. They heal unbelievably fast.
All right, and then lastly, and then we'll move on. For the mathematically directed osteotomy, I would say a lot of times have to cut the fibula. What does that do for basically like your concern for basically deformity of the fibula that you induce?
So fair, and I think any osteotomy with correction, whether that's an opening wedge, a closing wedge, a dome, correction with rings, are all going to induce the same deformity in the fibula. So I don't think there's anything unique or interesting about the mathematically directed osteotomy production of a fibular deformity. The short answer is I don't think it's a problem, and certainly make an elective fibular osteotomy remote from the ankle joint. But I have not seen that be a problem. But it should be identical on any of these osteotomies. I do a long oblique osteotomy of the fibula, typically not a transverse, nor do I usually cut out a section of it.
And then, sorry, one of the questions was in the chat section. Have you used medullary nail for a single plane osteotomy for the mathematically directed?
Never. And I can't say that it's wrong, but mechanically, it doesn't make me, that doesn't feel right. Plus you're looking right at this long oblique, perfect surface that's it's screaming for lag screws and plate neutralization. So I can't imagine that anything's going to heal, more quickly than a well compressed long oblique surface.
Okay, so for this section, the take-home points are that we went over the indications for tibial deformity correction with Sean's, particularly the mathematically directed osteotomy, and then non-union or a bone loss management with Mitch, particularly the transport component with the leg lengthening and bone transport with internal as well as cable assisted. And so we'll move on to Tim's talk about extra-articular deformity for the distal tibia. And let me stop sharing.
Yep, sounds good.
Oh, yes.
Two really, really good talks. Just some super complex topics taught by some really people excelling at that. This is going to maybe get a little bit more back to basics, I guess. Extra-articular distal tibia osteotomies. Our learning points over the next 10-15 minutes, I want you to appreciate the importance of the clinical exam relative to the ankle here. I'm going to hopefully go over a strategy for managing the fibula in these osteotomies. And then we're going to go through 4 cases that will hopefully give you some examples of what can be achieved relative to distal tibial osteotomies. So not unlike the hip and the knee, which we've already gone through, physical examination is super important. Relative to the ankle, though, range of motion is important to look at, especially, obviously tibio-talar, but especially subtalar. Oftentimes we're correcting either varus or valgus, and knowing whether that subtalar joint has enough motion to compensate for the position that you're going to be putting the distal tibia in now is important to assess beforehand. Sometimes you need to add a calcaneal osteotomy to that to be able to make sure that the foot is coming down flush to the ground. Viewing the patient both from the front and the back gives us a good understanding of what the clinical deformity is. Watching them walk just the same as with your other knee and hip deformities. But then with regards to the ankle, sometimes we can have a deformity that is brought on because of weakness, either in the posterior tib or the peroneals. And so assessing motor strength is important around the ankle. The ankle joint is a complex joint. You see it here with its complex articulations. It's interesting that despite all of these articulations, it still has only 1/3 the contact surface area as what the hip or the knee has. And so this is going to transmit the same force as the hip and knee, just through a smaller surface area, so much more prone to wear out. It has a complex motion. It's not just a simple hinge, but externally, your foot externally rotates as you dorsiflex and internally rotates as you plantar flex. The blood supply is actually quite good in this area, allowing us to be able to do our osteotomies and oftentimes get this to heal. The great majority of the time, we're going to be doing our osteotomies on the medial side of the ankle, either an opening or a closing wedge, sometimes a dome, rarely on the lateral side, although there are times where we need to be on the lateral side. The lateral side makes it a little bit more challenging just to protect our soft tissues, given that the fibula is there. So it can be a little bit more dangerous, I guess. It's important to look at your soft tissues and where previous incisions are. This particular area of the body does not tolerate small skin bridges. And so sometimes we're forced to, because of previous incisions, we're forced to make our incision in a little bit different place than we might want to, or may force us to do our osteotomy in a little bit different location than what we might want to. Typically, we're going to, anything with a 10-degree deformity or more, we're oftentimes going to be cutting the fibula and allowing it to essentially float or move with that distal tibia fragment. The one exception to that is a varus alignment with a widened ankle mortise. So we see the widened ankle mortise here, and by leaving the fibula in place in doing our osteotomy, our valgus osteotomy, or taking it out of varus, we actually reduce the ankle mortise at the same time and improve the overall symmetry of the ankle mortise. So Brett showed this slide earlier. The mechanical axis has been everything through the whole course and will always be that. It's important to know what the norms are. So for the distal tibia is in the coronal plane is about 90 degrees, in the sagittal plane 80 degrees. All right, so let's go through 4 cases here. This is a 25-year-old female who had a previous tibia fracture about 10 years ago. She comes in complaining of knee pain. Here's her x-rays showing her tibia is well healed. Her mechanical axis is not that far off, but when we go ahead and watch her walk, she turns her injured side, turns her knee internally rotated significantly when she's walking. When we put her prone and flex her knees up, her foot the position of her foot is externally rotated, and clinically it's about 20 degrees. And when we get our CT scan, that's confirmed on the CT scan that she has about a 20-degree external rotation of her at her tibia, or mostly at her tibia. I just want to, real quick, we've talked a couple different times in the course as to how we verify that we're actually getting the rotational correction that we want to when we're in the operating room. And I'll just give you a little bit of my pollution or my technique of how I like to confirm my rotational correction. So a pin, I use a 2.5 Schanz pin, and I do not use these as joysticks. These are strictly for assessing the alignment. One in the proximal fragment, one in the distal fragment, a third pin in the distal fragment. And I like to use my triangle there because this way I'm not trying to sight all the way down the leg, but just right there by the other pin, I can go ahead and accurately judge my correction. And then once my 3 pins are in, I can do my osteotomy. And then when I internally rotate in this situation, the tibia, the anterior pin, which was originally lined up with that proximal pin, now the posterior pin lines up with that proximal pin. And that way I know that I've gotten my correction. And I think it's just a little easier than trying to sight in the triangle all the way down the length of the tibia. So that's what this looks like. Here's our 2 pins distally. We did a transverse osteotomy here, relatively simple, corrected her 20 degrees, internally rotating her. This is her initially post-op and not her healing. Here is her pre-op and post-op mechanical axis, and we actually improved her mechanical axis slightly back more to normal, although it wasn't off that much. And here she is prone with equal symmetry, and here she is walking. Nice result. This one, second case, 13-year-old with a Salter-Harris growth plate injury, treated here with a cannulated screw. This goes on to heal and the screw is removed, but he's developed a physeal bar across that medial aspect of his physis. An attempt was made at trying to remove the bar with cranioplast put in the defect. Unfortunately, he continued to develop his angulation here at about 80 degrees, or I'm sorry, a 10-degree deformity with a distal tibial angle of 80 degrees. And so the decision was made. Actually, if you look at this image here, you can start to get that sense of this widened ankle mortise here on the medial side. We ended up leaving his fibula intact, and unfortunately we probably had Johnny running the C-arm this day because we didn't get any of the images that we saved. But doing an opening wedge osteotomy of his distal tibia allowed us to not only, and leaving the fibula, not only correct his overall deformity, but also make his ankle mortise a little more symmetrical. So here's our correction. distal tibial angle of 90 degrees now. And you see his ankle mortise actually looks much more symmetrical overall. Here he is with his hardware out. Case number 3, this is a 24-year-old with congenital valgus ankle. So she has about a 20 degree, almost a 20 degree deformity here. This patient was initially treated by one of my partners who did a closing wedge osteotomy of her distal tibia. And this is his initial post-op x-rays here. And when we draw lines, we see that actually it was somewhat overcorrected, both in the coronal plane and in the lateral plane, or in the sagittal plane. In the sagittal plane, it's almost, he's imparted almost a 15-degree deformity here of her distal tibia. She ended up not healing and breaking her plate, and this is where I was asked to help out. And we took, obviously, the non-union, the non-union here, the opportunity to try to improve that alignment. This is our post-op alignment, and it's not perfect, but it's much closer to our population norm here. This goes on to heal. And she just recently had her plate out, and she's been pretty happy with this. All right, last case. This is a 65-year-old religious minister who is quite active. He rides his bike about 1,500 miles a year, loves playing basketball, especially in their with the kids in the youth church league. About 8 weeks prior, he had some surgery of his ankle and states that he's been having pain ever since. He comes in to see you and states that he doesn't really feel like he can trust his ankle now. His weight-bearing films in the office are these here, and you see the talus subluxing out front of his ankle mortise. In the office that day, I did some stress views and was able to reduce his talus back into the mortise, but obviously not stable. After the office visit, we were able to get his pre-op x-rays, and you see those here, this large osteophyte on the front, which was really the only thing that was sort of capturing his talus and keeping the front door closed, if you will, or keeping the talus back in the ankle mortise. When you compare them to the stress view that I did that day, you can see the resection, a relatively aggressive resection that was done of the distal tibia, making the ankle joint unstable. So looking at his, quote, normal side, his opposite side, which he also has some arthritis there, he has a relatively normal sagittal plane on his normal side at 80 degrees. His opposite side, or his side now that he's having a problem with, because of the aggressive resection, now has essentially an inclination of his plafond of about 10 degrees more. Our thought was that maybe, because given his joint space here, his joint space actually looks quite good, we might be able to do a osteotomy and try to move the plafond back up over the talar dome. So we decided to do a posterior closing wedge osteotomy of about 15 degrees here, using 2.0 drill bits as our guides, and then our osteotomy with the wedge removed. We cut the fibula to allow it to float with the distal fragment, preliminary fixation, and then our initial fixation after surgery. This is our correction. I wanted to get just a little bit more than neutral on him in an effort to keep the hopefully keep the talus from escaping out the front of the ankle mortise. I also added an external fixator so that with a tibial pin and a calcaneal pin, our vector would be pushing the talus back into the ankle mortise. In an effort to try to do a little bit of a distraction arthroplasty of his ankle joint itself, we added some traction during his office visits. We took the fixator off at 6 weeks, and honestly, I had a fair amount of chest pain when I saw this lateral here, wondering if we were ever going to be able to keep this talus back in the ankle mortise. But at 8 months, he's settled in nicely. Here he is at 2 years. And we tried to get him back in, but he's now 70 years old, has not had any more surgery on this ankle, and doesn't really want to come in just because of the virus right now. So, so in conclusion, I think it's really important, especially the ankle, because of most of our osteotomies being either in the coronal plane, looking at subtalar motion and making sure that the subtalar joint can compensate for whatever position you're putting the distal tibial fragment in. Most angular corrections can be done from the medial side, and that makes it much easier to protect the soft tissues. Fibular osteotomy for anything over 10 degrees and allow that fibula to stay with that distal fragment and seek its position. And then, like so many of the other osteotomies, right, restoring normal anatomy, oftentimes the patients end up with a significant improvement, if not a great deal of improvement. So, all right, thank you. I'll stop sharing my screen and allow Brett to take things back over.
All right. So we're going to go on to the next section, which is intra-articular distal tibial osteotomies that we're going to go through a few cases. But before that, I just wanted to kind of outline some typical scenarios, at least that I've encountered. So probably the most common situation, and this was the same for around the knee, is that it's a delayed fracture presentation. So several weeks or months after initial injury. And then if they have a true intra-articular malunion where it's completely healed, and then somewhat along the same lines as what Tim's case was, except involving the intra-articular anatomy, which his exactly was, I guess it was an anterior plafond, but joint instability and how to address that. And so it wouldn't be a course in AO around the ankle without mentioning menisca and the strayer. So just remember that if you have the talus wanting to extrude out the front, don't forget about soft tissue release, which would be a gastrocsoleus recession or something to improve ankle dorsiflexion. So don't forget about that. So the kind of the parameters that we use, Tim just discussed. So really around the ankle, we're looking at that lateral distal tibial angle of around 90 degrees. And then on the sagittal plane, it would be the anterior distal tibial angle of 80 degrees. And with intra-articular involvement, obviously we're going to get some advanced imaging. And so CT scan, I think, is critical. But, you know, maybe sometimes depending on the clinical exam and what you feel like their ligaments and potentially tendon issues are, an MRI would be helpful. Or if you specifically want to look at the status of the articular surface, that may be helpful. So this is the first case, which is actually Sean's case. So I'll let him go ahead and present that, and I'll try to advance slides appropriately.
Yeah, thanks, Brett. So this is a 59-year-old woman who you can see her distal tibial intra-articular injury on the left side. For some reason, they opted for non-operative treatment, and then ultimately she showed up at about 14 weeks. And I think next slide, Brett. These were back from her original injury films. And so I think everyone can appreciate, this is a variant of a posterior pilon, and I think we have some CT images from this with kind of just the classic external rotation deformity. And it does involve about 50% of her joint. And just so we can, I think, go ahead and get to her non-healed subluxated ankle joint. Those are the original 3D CT scans. And this is what she looks like then at 14 weeks. And so I guess I'll just maybe put it out to the other panel members, what their initial thoughts are on this. She's actually, putting weight on this, but it's quite uncomfortable. But she does have some ankle stability.
I think for me, the main concern is that talus impingement on the plafond and how quickly that will go south if she continues to not get her joint stability addressed.
Yeah, this sure would have been a lot more fun 14 weeks ago.
Right. I mean, that is kind of like one of the more satisfying fractures about the ankle or tibial pilon variants is that pattern, because this is one of, there was no impaction. This was a pilon where one could truly get it perfect, right?
Yeah.
Yeah. So this is the CT scan that was obtained just a little bit before the I think maybe a week or two before. And it certainly shows what Brett referred to. I mean, the poor talus is just sitting right there on the articular edge as it's subluxated so far posteriorly. And you can see some callus formation within the gap of the original fracture. I think what you don't see well, though, or we certainly discovered intraoperatively, is right there is some callus, but I think it's impressive how much more healed this turns out to be than the CT would suggest. I mean, someone might look at that and say, I'll just clamp it. Do not be fooled. Does anyone have any thoughts on how to attack this?
Yeah, I just think it's these are super hard at this point because getting that cleaned out is really the key. You can't get this closed down or get back to that sort of normal ankle anatomy that I showed in my talk, those cross sections, which is really impressive when you sort of look at the ankle in that view. To be able to close this down and get it back is really tough once you start getting that much callus in there. And then on top of that, the clamp really has to go from back to front. It's just a hard trajectory to get and not crush soft tissues and not have a big sort of clamp in your way. It almost has to be a plate reduction, pushing with the plate, but these are hard.
I think the biggest question is, do you try to do it all through a posterolateral approach? I would be a little bit hesitant to only do that, because I think if you do a posteromedial approach, you should be able to, in addition, you should be able to see, at least distally, you're going to see the joint surface better, or at least get a peek at it as far as how well aligned it is. And so as long as their soft tissues could handle both approaches, I think that would be the exposure task that I would do.
And then Tim, how to regain length on these? Because she's been posteriorly subluxated and short now for quite a period of time.
Yeah, I think that, obviously your distractor is going to be very helpful. It becomes a soft tissue issue as well. I would start with trying to do a gastroc slide and see how much I got. I really am not a fan of doing an Achilles tendon lengthening, just because I think it really does weaken the overall system. And, you know, patients in the operating room, you know, putting a lot of distraction on and then trying to go and do something else, work somewhere else. I also like using a lamina spreader, sort of a poor man's distractor. I'll put, you know, a 062K wire in the fragment itself and be able to, with the lamina spreader and a couple cokers onto the K wire and the foot of the lamina spreader, be able to distract with a lamina spreader, then not necessarily in the fracture site, but just trying to gain length that way.
I was going to ask Mitch, since you are you know, savvy with the circular frame, what do you think about doing gradual distraction and then coming back?
I probably would not do it here. Just from the lateral X-ray, for me, I think more of buttress mode, so posterior approach and buttressing the posterior malleolus. I agree with Tim's comments before. I think cleaning the fracture is difficult at the articular surface. Getting the apex of the deformity, I think, is not that big of a deal, but shutting down the fracture line at the articular surface is I've done two of these. I can't shut down the fracture line at the articular surface, but getting the ankle reduced is not that difficult. I agree with distracting the fibula, then distracting the posterior malleolus using push-pull screws and working that way. But closing down the articular lesion is very difficult.
All right.
All right, Brett. So I think everyone's point was good, and the shortening turned into quite a intraoperative project in addition to trying to get callus out. And we certainly did have to recreate the original fracture with osteotomes, both through the fibula, as well as from cranial to caudal, as well as from the medial side. So we certainly started with the distractor. The second pin is through the incision directly posterior to anterior through the posterolateral approach. And we had to progressively did a gastroc slide right off the bat in addition to it. But I was probably struggling more with the reduction, but we did do a percutaneous tendo Achilles lengthening. I couldn't do it because, like Tim said, it makes me feel ill. So I made Ben Ershka come in the room and do it, and then go back to doing a gastroc slide in room 14, which is what he does all day, in addition to complex problems. And then the problems that everyone identified, just recreating the fracture with an osteotomy, cleaning it, and you can see even with clamp applications, it's still not compressed. So to Mitch's point, clean for hours, and still it's so difficult to get that last bit of compression. And then I think we did go with independent lag screws and buttressing plates posteriorly, and the same thing with the fibula to assist with pushing that forward. But you can still see the slight articular incongruity. And then I think we have subsequent films of her immediately post-op and then after healing, and that's her at 9 months. You can see her joint is a little bit sour already, even at 9 months. She hasn't had anything done subsequently. She's about three years out, but stay tuned.
Well, she's lucky she had you. Can I just ask a quick question on that medial fragment? Like, how did you see that? Did you externally rotate the posterior fragment to then be able to see and clean out that medial fracture line there?
Yeah, so I did the bulk of the work through posterolateral and posteromedial approaches, but then I also added a third small direct medial right over that component of it to free it up and to put in an osteotome right along that line. So that exit point at the anterior aspect of the medial malleolus.
Yeah.
Yeah, so I had to kind of have osteotomes in 3 different locations: through fibula, cranial to caudal, and directly medial.
So I think that, sorry, I think the take homes were that the CT scan's critical, gaining length, even sometimes if it's 2 weeks, can be really challenging in these fractures. Utilizing the previous fracture lines are really helpful and kind of give you the plane that you need to go through, and then using standard fixation principles like Mitch said, getting buttress fixation and then also compression across the joint. And so just we'll try to just move through this a little bit quick. So this is a lady that presented to me 3 months after this medial X-fix was applied and fibula plated. And so the challenge to this one is that I can't show you her CT scan because this was about 2007 and I couldn't get the films back, but the 2 yellow lines represent a lot of her anterior plafond, so significant impaction. And then if you look at it on the lateral view, she's subluxated anteriorly. And so usually that is a bad, it's like the harbinger of sorrow for pelons. And so she's 62, she wants to remain active. She has significant articular impaction and comminution and joint subluxation. And so the options that I thought of were osteotomizing her. On the CT scan, it showed that the articular surface was partially healed. I mean, there's definitely callus there. Really osteotomizing her main articular fragments and getting them down and supporting it. The other option would try to be a tibio-talar fusion, which I think would be challenging with that amount of bone loss. Hindfoot fusion with intramedullary nail. You know, if somebody wanted to go crazy and do a total ankle, that would be an option, I guess, versus below knee amputation. What are your guys' thoughts?
Pretty tough. I think that, you know, if the one thing that we haven't learned in this course, then maybe we won't learn, is that oftentimes we can get a fair amount of this stuff back and functioning. So I'm not so sure I'd be so quick to go to a hindfoot fusion nail unless there was, you know, a reason to, you know, some other reason to push me to try to fuse this. A tibio-talar fusion is going to be really hard to do without that anterior bone stock. And so now you're sort of back to, if you're going to try to recreate some anterior bone stock now, trying to go ahead and fix it and see how it does. See if there's some of that articular cartilage you can free up and get back down. It's not going to be perfect, but if you can provide some sort of articular reduction, I think it's reasonable. I don't think a total ankle is a good idea in this, you know, with the deformity that this patient has.
Any other thoughts, or everybody's on the same
page as Tim?
Okay. All right, since we're getting close to time, I'll kind of move through it. So this did an extensile anterolateral exposure. You can see that's part of her joint surface. That's part of her joint surface. And then this is the amount of bone void that she had. You can see that her talar body surface wasn't actually that damaged, which surprised me. And it may have been because she's a little bit older and her bone kind of failed a little faster. But this is what I did. I used her ipsilateral femur for bone graft harvesting to support the articular surface, as you can see here, and then used 2 or 3 plates. And obviously her joint surface is not congruous, but it was stable. And so this is her anterior distal tibial angle was 83.5. intraoperatively with the distractor on. This is what it looked like immediately post-op. This is what her angles at that point. So actually plain film showed a little bit better anterior distal tibial angle. Her lateral distal tibial angle wasn't bad. So within kind of normal parameters. And this is her 33 months later. She obviously is getting some ankle arthritis, and she fell into some varus as she was healing. You can see that on the mortise view. But she ambulates without any assisted device and has about 5 degrees of ankle dorsiflexion with her knee straight. So that's not too bad. And she has pain with prolonged weight bearing. And so these were her final angles on those films. And so she did fall into about 5 degrees or 6 degrees more varus, but her anterior distal tibial angle stayed around 80. So the take homes from the intra-articular session is, particularly for this case, would be don't jump to fusion. You can use standard fracture principles. Obviously in elder patients that are older, the bone's not as easy to deal with, so you have to be super careful with that. And I think for both cases, as evidence, when you get a delayed presentation, getting anatomical reduction can be very challenging. I think we're gonna just move forward with the summary for this total session. So utilizing deformity correction to restore extra-articular alignment, as Tim showed, you can use in all of the sessions that talked about rotational correction, using the pins as guides and putting them in the amount of deformity that you're going to correct. And so your pins line up after your correction is super helpful. And then utilizing previous fracture lines is helpful for if it's a delayed fracture presentation for intra-articular osteotomies. And honestly, that's the most common situation that I've encountered. And so we're going to go to the summary here real quick for the entire day. And we'll try
Brad,
to get.
You don't have a hyperlink to get you to the last slide there.
Thanks for bringing that up. So the take-home points for the entire module were to list the indications for tibial deformity correction and non-union management, utilizing extra-articular techniques to restore alignment, including the mathematically directed osteotomy, which I would really encourage everybody, if you're thinking about doing it, go back to the YouTube video when it's posted or when you receive the Zoom link, and just spend a lot of time going over it. I've done these before, and it takes me what seems like 6 hours to plan them. Utilize techniques for the intra-articular osteotomies, and then, as Mitch has shown, leg lengthening and bone transport techniques are really useful tools to have. So this is a way to get to the last 2 sessions that you can register for. So this is on the AONA page. AONA.org webpage, and the Osteotomy Weekly Splash page will let you learn more. You get to this section, and you have to register for each one, because that's how they give you a unique identifier to get CME credit, as well as making sure we know who's all there. And then we will be sending a link for the live event as well. So we only have 1 Saturday left. We appreciate everybody that's been sticking with us, faculty and attendees. So hang in there. We've got 1 week left. And just remember, all of this is available online. So the Zoom recording link will go out today or tomorrow. And then you will get a YouTube notification, and you can go to all of them at the AONA Trauma, AO Trauma North America YouTube channel, and the playlist is the osteotomy course, as you can see there on the right of your screen. And all of the sessions are together, the modules are together, and then Michael Sirkin has separated out each individual lecture in each session, so it's so easy to catch up or go over specific segments. He spent a ton of time doing it. So with that, we'll end the module. We have a couple of questions for you. So the first one will be, for those of you who've participated in all of the discussion groups, how you prefer to do it. So we had it where we had multiple rooms with maximum of 20 participants versus fewer rooms with more faculty and up to 50 participants, versus last week we had panel discussions where faculty presented their own cases. and had the other panel members discuss their cases and critiques or different ways of doing it, and then also allow you to ask questions. And so we'll let you answer this polling question. And while you're answering those, just remember that the live event is going to be coming up in November. And so we want to try to get an understanding of how many people are interested. And so if you can please, when you receive the email invite, please respond quickly, because there are a limited number of stations and a limited number of participants that can be involved. And we're trying to gauge, do we need to do other live events in different areas of the country? So like we've thought about Miami to allow for Latin American participants to make an easier journey instead of going to Las Vegas. So we're trying to use it as a planning idea. And then also we'll have a polling question on Thursday and Saturday to ask you that as well. So thanks again for joining us. And we'll see you on Thursday for the Meet the Experts session.